Hello, everybody. I am honored to be here, especially in such esteemed colleagues, this presentation. And so this is, like Dr. Peterson alluded to, this was going to be the second time that we did this presentation together, and the hurricane actually hit my hometown right before our last conference. So he was kind enough to present my slide. So I'm excited to be able to share this with you today. All right, so disclosures. I don't have any financial vested interest in RGCC, which is the company that makes the SOTs. That being said, I must say that as an RGCC practitioner, I ordered a lot of their cancer tests for my patients, and I ordered a lot of their SOTs as well. As a practitioner, they actually provide you with free therapies and PCR testing. And so about 2 years ago, I found out that I had Lyme, and I'll get more into that in some of the case presentations. But I personally have taken 10 SOTs, also given SOT for my mother for cancer every 6 months. And I've given my wife 4 SOTs, and I run cancer testing and PCR analysis on my mother and father. So I think that has some inherent bias. So I just want to be totally transparent about that. And yeah. And so, okay, clinical pearls. I think these are some of the big things. Dr. Peterson did a great job alluding to the fact that this is not a panacea. It's not a magic bullet. And I have patients that come to me saying, hey, I want this SOT for my Lyme and my life's magically going to get better, right? And I have a lot of cancer patients who do the same thing. They say, hey, I'm going to go vegan and meditate and do IV vitamin C, and I'm not going to have cancer, right? I'm like, sorry, it just doesn't really work that way. And so it is super, super important that you address all the other issues why they're presenting with Lyme in the first place anyway, right? It's the mold, it's the chronic stress, it's the adverse childhood events. It's the multitude of other issues in their life. That being said, as a lot of SOT can be fairly controversial. And sometimes it's because people have life-changing healing experiences. And then other times, it's totally flat. People don't get any benefit at all. And then the question is, well, why is that, right? And that's what we're here to kind of teach you about is, if you're going to give an SOT, how do you make it as effective as possible, right? Because people are investing money, right? Most practitioners are charging somewhere between $2,000 and $3,000 per SOT. And so if you're going to have the patient give that type of financial investment, how do you make it worth their while? And they can be extremely effective when given in the right clinical context. All right, so our learning objectives here. We're going to learn the science behind the SOT, which you've already understand a lot of from Dr. Peterson's presentation, and then Dr. Louis did a great job yesterday explaining some of the basic science underlying that. And then we're going to talk about how it works on Lyme and co-infections, which is the most specific to here. I also use SOTs on cancer patients, but that's a little bit of a different story and probably not as many of y'all in here. Is anyone else in here treating cancer too? Cool. Yeah. And then increasing SOT efficiency or efficacy. All right, so what is an SOT? So we've already gone over this, so I won't belabor it too much, but just kind of going over the basics. So basically, it's going to be a single-stranded, a small interfering RNA particle. It's going to be complementary to the gene of interest. So specifically, right, with Lyme and viruses and Bartonella, Babesia, those kind of things, they're going to look for a specific replication region primer of, like, say, DNA or RNA that they specifically are aware of. And then they're essentially going to build a complementary strand that's going to marry that essentially when it matches it in the body, and it's just going to basically prevent gene expression essentially. So you're just going to shut down that whole like transcription translation process. So I like to think about it kind of like a Pac-Man birth control. They're going to make this specifically, for your target pathogen in your body. And then essentially they're going to replicate it and make it 500,000 to 1,000,000 times. And then you're basically going to get a small vial for your patient that's about this big. And the very bottom of it, it looks like a desiccated teardrop. Then you're going to reconstitute it with sterile water and inject it into the patient. And there's about, like I said, there's a million of these little particles going around. So what they're basically doing is just traveling 24 hours a day, 7 days a week. And they'll last, at least 4 months out, but then the efficacy lasts for up to 6 months, and then it tails off after that. Okay, so antisense therapy, as is already mentioned multiple times, so I won't go into it over and over and over again. But basically, what we're using is just basically RNA interference. So we're just shutting down specific gene expression. And that's going to be very specific to the different targeted pathogens, like Dr. Peterson mentioned earlier. Let's see. And then you can read all this too, and I have the references in the back too. So if you want to dig more into the science, obviously, you're definitely welcome to do that. So that's actually a video, and you should be able to link to that, hopefully. And so these are studies on antisense technology. Antisense technology has been around for at least 20 years. A good friend of mine who's a radiation oncologist in Asheville, I was telling him about SOTs because we treated cancer together at UT Medical Center. And he said, "Oh, that's so cool." He goes, "I did my PhD thesis." He's an MD PhD. He goes, "On antisense technology." He goes, "At the time, though, we couldn't keep the oligonucleotides stable in the body long enough to make them clinically viable. And so there's been a lot of technology that's developed in the last 20 years to do that. And there's a couple different like oligonucleotide backbones they use. And if you want to dig into the research on that, you definitely can." Um, okay, so once again, these are just complementary nucleic acid fragments. They typically are about 12 to 25 nucleotides in length. And so they're very, very small, right? But they're looking for those specific regions that they're going to bind to. And they're very specific too, right? And so they're not going to bind to any other cells in your body, right? If you get a Borrelia burgdorferi SOT, it's only going to bind to Borrelia burgdorferi. It's not going to bind to Bartonella or Babesia. It's not going to bind to EBV. It's not going to bind to your human cells. And even when we do this for people with cancer, it's only going to bind to the cancer cells. It's not going to bind to their cells at all. And what's interesting too, I guess I'll tell you about that in just a minute. Let's go to the FDA approval, because this is really important, right? And this is something that got me a little leery at first. Oh, it's not FDA approved. Is that okay for me to use this? Am I going to get in trouble? Okay. Well, first of all, we use a lot of medications off label. Well, this is a little different category, okay? So it's not FDA approved because it can't actually be FDA approved. To be FDA approved, you have to have a medication that's typically kind of like a one-size-fits-all. If someone has acid reflux, right? Like I don't use omeprazole very much, I try to get people off of it all the time. But like omeprazole is going to work the same for every single person in this room, right? You're not going to make a specific omeprazole for the gentleman in the front row or the lady in the back row. It's just one med fits all, okay? And SOTs are the exact opposite. Every single time you send in for an SOT, it's going to be a brand new specific SOT. Even with cancer, if I give someone an SOT now and I give it to them 6 months later, it's a different SOT because their circulating tumor cells have changed. It's the same way with this. So this is actually considered like an advanced biological product. And so it's going to actually fall into the category more similarly to say PRP or stem cells, right? Because it's autologous material. And then you can make the argument, well, like, it's not really my cells, it's the cells of the Lyme, right? The bacteria. That being said, though, it still came from your body, so it still kind of falls under that category. And so, yeah, that might be a little bit of a loophole, but that's the way it works. So in the EU, these are sanctioned, right? And they are considered these advanced therapy medicinal products. I don't know if I actually had like a little shiner on this thing. I guess not. But anyway, cool. So they're called these ATMPs, right? And they're sanctioned by the EU Regulation 1394, 2007. You can see all that. But they're sanctioned by the European Commissions. And then yesterday you heard too that there have been some issues with Europe. I think I can't remember when it started, maybe in Poland or something. It kind of became a political thing. Anyway, but in the US, you're good to go. And I've never had any trouble. And as far as getting them here too, basically what happens is, we send the blood off. It takes about, a week to get to Greece. It takes about 2 weeks to make these SOTs, a week to get back. I've had them stopped in custom maybe 3 or 4 times, but they always come out a week later. And so, yeah, I don't think at this point in time, you have anything to really worry about. I wouldn't give them if I was worried about, my license or anything like that. I think it's just really important that you just give the patient all the information, and let them know, hey, this is not 100% guarantee your Lyme's going to totally be cured, but that's just being ethical and responsible as a clinician anyway, right? I tell people it's kind of like going fishing. I'm going to give you the very best bait and take you to the honey hole, but I can't promise if you're going to catch a whopper or if you might not get a couple bites that day. Okay, so these are all these different SOT primers for Borrelia burgdorferi, but this is some of the, basically some of the RDCC, the company that makes the SOT, some of their basic science predating the actual SOT. This is when they're finding out these primers. So this is some of these different backbones that they're actually using to make the SOTs. And they'll actually do different ones. It's interesting, even for Borrelia burgdorferi, it's not just one SOT, because I always get confused about that. I'm like, so if I order a Borrelia burgdorferi SOT, are these things just sitting on the shelf? And they go, okay, it's a Lyme, it's a Borrelia burgdorferi, send it off, or it's a Borrelia hafzeli, send it off, and they're not. They're actually looking for which one of these primer sequences they feel like is going to be the most important for replication based on the load they find in your body, which is really interesting. Okay, so once again, what I explain to patients, it's like a Pac-Man birth control. These things are just going around gobbling up, basically just connecting, right? It's like birth control because they're marrying these cells in your body, these genes in your body, and then they're just basically impotent, and so they're not fertile. They can't reproduce. That's really in a nutshell the way it works. But this is kind of a gene silencing recap. I think we've talked about this multiple times. But like I said, this is going to remain active in the body for 4 to 6 months. So once again, yeah, if you give it to somebody, you can't take it out. So just be aware of that. It's always try to prep people before, and I'll go over some of the different supplements that I use to really prep people and give them maximum effectiveness for these. All right. And once again, this is not a gene therapy, right? This does not change your genes whatsoever, so it's not a gene therapy. It's important. Okay, so everybody knows what Zlotes looks like. All right, and then what can we treat with an SOT? Because this is really important, right? Because it's got to be practical. Okay, so the different strains and species you can treat with SOT. There's 19 different Borrelia species that you can use, including all your big hitters. There's 6 different Bartonella, 6 different Babesia species. There's Anaplasma, Rickettsia, and then Ehrlichia as well. I've never actually given anyone SOT for Anaplasma, Rickettsia, or Ehrlichia. I usually just treat that with some like Doxy, and kind of knock it out, or herbs. But I have used it extensively for Borrelia and Bartonella and Babesia. And you can talk to different clinicians who do a lot of SOTs, and everybody has an opinion. It's like everything else in life. A lot of practitioners like to go after the co-infections first, like the Bartonella and Babesia. They feel like there's less like herxing and reactions, and it makes it more effective, and go after Borrelia burgdorferi. To be completely honest, just in my clinical experience, it doesn't mean it's right. I have found that if you were only going to get one SOT, obviously go after the one that has the biggest infection. Obviously, if you catch it on PCR, I would go after that one versus something that had high antibody titers. Then I'd go after IgM titers before I'd go after IgG titers. But that being said, if all other things are equal, I have found that the Borrelia burgdorferi, I feel like my patients have the best outcome from. But once again, that's totally anecdotal. And what's cool though about the lab, because this is like kind of space agey science, right? And I'm kind of like, is that real or is that kind of BS? It's expensive. I'm not going to be promoting something that I don't feel like is totally authentic, right? A couple of different things have made me feel really comfortable with this. One is I actually did go to the RGCC International Conference. I guess it was last year. Dr. Peterson went, and I saw one of the other colleagues here that was there too. But they were so sincere. And that doesn't mean they know everything, right? But I mean, I could tell these scientists had like devoted their entire life to this, just like you've devoted your career, to helping people with Lyme disease and other co-infections. So just like knowing them on a heart to heart and soul level gave me a lot of confidence in their intentions. Second thing is, proof's in the pudding, right? So money drives a lot of actions in life. I have sent off SOTs for people or blood for SOTs, and I said, hey, make an SOT for X, Y, and Z. They said, hey, I'll make an SOT for X and Y, but I'm not going to make an SOT for Z because we couldn't isolate it on our PCR analysis. So if we can't find it, I'm not going to make it for you. Here's your money back. And that's really cool. That's happened a couple times. So that also, to me, validates that, they're not just BSing. This is the real deal. Okay, so this is a paper that Dr. Peterson talked about. Okay, this is a SOT therapy, and I got the down here too, the citations, so you can check that out. But this once again kind of goes over it, and then these are some of the results from it. And so this can be a box plot. So what you can see is they do these spins, okay? And then if you ever order, RGCC has a sister company called BioCentaur, and not a lot of people actually know this, but BioCentaur, they do PCR analysis. They have what's called a PALDI spot, which is checking for Lyme and all these Lyme co-infections. They have what's called a prime spot, which is checking for like, all the viral infections, EBV and HHV6 and so on and so forth, HSV. Okay, so what happens is when you send the blood there, they're going to run their PALDI spot and prime spot and their PCR test. And I've actually found their PCR test to be really sensitive. They do a really good job on the PCR. They don't do any antibody testing, but they do the PCR. And so they're actually going to run it through this, okay? Now, what happens is they're going to do like 35 spin cycles, essentially, and like that's a whole other thing for what all that means. But basically, the lower the number, what you're going to see here is the higher the concentration, and so they'll spin it 35 times, and if they don't find it, okay, so it gets a little more confusing. But if you have a positive test result, they'll actually spin it more. Okay, they'll spin up to like 40 times, and what you can see here is there's a rise right from the first to the second, from no SOT to one SOT. And so what that basically is, and I'm not sure if it's like if it's exponential, algorithmic, or exactly how they denote this, but it's basically it's a PCR quantification of the amount of the pathogen DNA that they isolate from the blood. And so they did that after it's one SOT was statistically significant, and then once again you can see after the second SOT it gets better again, but just after one there's less PCR analyzed, say DNA in there. Okay, so this is important. People, well, can I just get one SOT for everything? And the answer is no. Well, can I just get one SOT for all Borrelia or Lyme? The answer is no. But as was mentioned earlier, what we see commonly is if I go after the biggest offender, right? Like a lot of times it's Borrelia burgdorferi. But if I go after that, I will see Borrelia afzelii, Borrelia miyamotoi. I'll see multiple different Borrelia strains decrease on the antibody titers when I follow up, say 6 months later. But I'll also see the Babesia and the Bartonella titers drop too. And my theory on that is that you've taken off some of the immunological burden, right, by going after the biggest offender. And so the body's able to go after some of these other infections again. And this is some of the efficacy based on that study, 95% for Lyme, and then it was a 91%. Now, I'll be totally honest, like this was mentioned earlier. This is, internal data as all data is. I haven't seen it be that effective, honestly. I would say anecdotally, I'm closer to probably 80-ish%, just to be totally honest. But it's still super, super effective. But like 95%, I wouldn't say I've seen it to be quite that high. But once again, that's totally anecdotal, and I'm trying to do a better job attracting like MSQ scores and MSIDS scores pre and post. And we've talked about that, and that needs to be done. We need to do more of that because it's a small study. Okay, but how do we maximize the effectiveness? So we got to make sure that detoxification pathways are open. We really got to work on chronic stress, on the whole HPA, thyroid gonad axis, lifestyle interventions, and then you really got to look at all the co-infections and the mycotoxins. And what I found a lot is, if you don't get rid of the mycotoxins, the Lyme's never going to get better. I'm sure everybody here knows that already. Okay, so let me kind of give you some of the nuts and bolts of how to actually work this out, because you're probably thinking, okay, that sounds great, but how do I actually do this? So what you need essentially is just a positive test. All right, and that could be a great test from like IGenix, it could be Vibrant, it could be the PCR testing through the company, through the Biocentaur. This could be a Quest EBV early antigen test. It could be a Western blot. It doesn't matter. Just a reputable lab company, okay? DNA Connections, whatever. And so you get that positive test result. And then what you do is you do a blood draw. Then you send the test results in with the blood draw to the company with the order confirmation. Okay, and then they're going to do their PCR analysis and spin it down. If they can't find it, which is very rare. It probably happens less than probably 2 or 3% of the time, maybe even less. Then they're not going to make the SOT. But if they will, then they're going to make the SOT for you. Okay, and then each SOT is shelf stable for 6 months. Like I said, it comes in a little tube. It's about this big. You can put it on the shelf and then wait till it's time for the patient. You can split the dosing, but I wouldn't recommend that. That doesn't. In some of my really fragile cancer patients, I've done that in the past, but I don't think it's necessary. You're going to super saturate them, anyway, with these SOT particles. So there's no reason to split the dose. All right, and then you had to get a fancy freezer, feed it for more than 30 days, and all that. So I would just give it all at once. Okay, so treatment timing. And so there are limits on this, okay? So you can only get 9 SOTs in a 12-month period, okay? And you need to give them at least a week apart. What I typically do is I give them a month apart. That gives the patient plenty of time to recover from their previous SOT if they do have any Herx reactions, and then kind of get queued up again for the next go-round. This is a long-term thing, and these are big hitters. So I always tell people, hey, like, 1 a month is plenty, you're good to go. And very few people are pushing that boundary of trying to get 9 or in a year anyway. I personally took 10 of them, and I did it over the course of about 14 months, and that was pretty aggressive. Most people aren't quite that aggressive. And then you got to wait at least 3 months between the same SOT. So let's say you're doing Bartonella henselae, you can't do Bartonella henselae back to back. You got to wait at least 3 months in between. Okay. Yeah, and you never do 2 on the same day. Like this is like really, it's like the smallest and most potent medicine, per milligram that I know of, at least on the planet. There is a pre-medication with dexamethasone, and that's essentially just to tighten up the vasculature so you don't leak anything into basically the extracellular fluid, because you want everything to get into systemic circulation, right? Like I said, it's expensive therapy. You want to make sure you maximize that. And then optionally, you can do like an IV famotidine. If you don't want to do that, you can just tell them, hey, take an H2 blocker that day, make sure there's no histamine reactions. The company recommends that you can do acetaminophen. I've never given anybody acetaminophen, never had anybody that needed to take it. Had a couple of cancer patients who had a little bit of a fever, like the next day, and I just don't take a little ibuprofen, and they were fine. But yeah, so just that's the only pre-med really is dexamethasone plus or minus famotidine. And like the whole process literally takes like 30 minutes. And it's something that your nurses can get trained on. Okay, cool. And let's see. Yeah, so this is important, okay? So when you get these, there is a lot of education that goes with this. A lot of education, like a lot of preparation. Patients kind of have to understand how to make it as effective as possible. So what you want them to do is you want to be off any kind of, and this is pathogen specific, right? So for instance, let's say that they have Bartonella babesia and they have Borrelia, okay? Let's say they're taking Mepron, but they're not going to get an SOT for babesia. They're only going to get an SOT for Borrelia burgdorferi. Well, you can leave them on the Mepron, right? You know, because it's not, say, affecting the Borrelia burgdorferi so much. But if you're doing SOT for Borrelia burgdorferi, you got to get them off all the antibiotics. And then, you know, herbs have so much more coverage, right? They're so much more broad than some of the antibiotics. And so you got to get them off any of their anti-Lyme co-infection herbs. Ideally for 2 weeks, at least a week. Okay, and the reason for that is methylene blue too, like Argentyn 23, colloidal silver, any of the IVs like ozone or vitamin C or anything like that. Yeah. And the reason you want them off that for at least a week, preferably 2 weeks before and then a week after their SOT, is basically because if you're killing these pathogens, these bacteria, these viruses, what's going to happen is you're essentially going to have shrapnel, right? You're going to have these dead bacterial pathogens, and there's DNA shrapnel just floating throughout the body, throughout the system. And the SOT, it's a great therapy, but it's not smart, right? It can't identify, oh, you're alive, I'm going to save myself for you, and then, oh, you're just dead DNA floating around. It doesn't know the difference, right? So it's going to bind to it, so you're going to waste part of your SOT. And so that's what I tell people. It's like, this medicine's plenty strong. Don't worry about it. It's okay. Because some people get like really attached. No, I have to do my IV vitamin C a lot. This is more my cancer patients. Or I have to be on my, my methylene blue, or I have to be on my antibiotics, or I have to. It's like, no, this is plenty. Like, let me just reassure you, this is the strongest thing you've ever taken. This is enough. Take a little vacation from your herbs for a little while. And then if I'm giving people multiples, like a month apart, then I'm just like, hey, take a little vacation. For the next 2 months, you're just not going to take your herbs. Otherwise they have to start, stop. It's easier just to like, let me reassure you, it's why you're taking this medicine, right? Take a vacation, relax, get one of these a month. And then when you're done with this, then we can restart the methylene blue. A lot of times too, what I'll do is I might time this where I start this before I do like a longer term protocol with like methylene blue and all that. And I like to synergize them too, right? Like throw that on top. And these are things that I have found that make the SOT, let's say, more effective, increase detoxification pathways, and prevent peroxisomal reactions. And we've gone through a lot of different supplements and herbs, but these are ones that I've found repeatedly to be the most effective. So I think number one, liposomal glutathione, and that's going to help too with the mold, right? And then some type of anti-inflammatory herb, because there is going to be like a big cytokine release for most people when they get these SOTs if the infection is big, especially the first time. For instance, when I got my very first SOT, I came home that day and my wife looked at me and she's like, "What is wrong with you?" So what do you mean? She said, "You look white as a ghost." And I was just totally just like ashen white. And I had to learn how to like detox all this dye off in my body. And I actually got to be really good friends with a coffee enemas. I'm not sure if your patients have done that before, but that was honestly the only thing I found that could just clear everything out of my body. Now, 6 months later, when I came around for my second Borrelia burgdorferi SOT, minimal effects. But I think it's kind of thing. If you have a huge burden in your body, the die-off's going to be harder, right, than if you don't. But the quercetin can help, especially if someone has like MCAS or if they need some histamine support there. Some of these proteolytic enzymes I think can be helpful, but I tend to like, and Blue K, if you don't know, it's lumbrokinase, so super potent. But I like to start these later. I don't think it's really necessary to go after and start killing all these like bacteria, and then at the same time, bust open the biofilm and release those too. So I'd say, like incorporate, more of the biofilm busters a few weeks after, maybe a month after, maybe even 2 months after, depending how sensitive the patient is, just so you don't overload their system with, too much die-off. And then binders, right? Because they're going to have a lot of waste that they're releasing in the body, so you want to help suck it out however you can, as well as sauna, or enemas if they need that, whatever works best for them. Okay, so contraindications and safety. So this is important. It's a no-go if you're pregnant. It's a no-go if you're breastfeeding. What I would say is if you have a patient and you like let's say it's a woman who wants to be a mother and you know she has like a Lyme infection or and if you can get her like 6 months prepping her for her pregnancy, that would be the ideal situation, right? To really lower that burden prior to her getting pregnant to decrease the risk of her, transmitting that to her child congenitally. I think this is like awesome, like really pre the earliest prenatal care. And then kids under 5. My daughter has gotten Lyme at least once, and I'm kind of and she's about to turn 5, so I'm kind of at the point now where I'm looking at maybe doing a PCR test. When it comes back positive, I'll give her an SOT. I mean, that's how safe I feel like these therapies are. And like that's my kid, right? So obviously I wouldn't do that if I didn't think it was safe or really effective. And then, are there any adverse reactions? Yes, someone can get like flu-like symptoms. They might get headaches. They might get fatigue. They might get a Herxheimer reaction. But like Dr. Peterson said, it's usually not horrible. It's way better than antibiotics. I see people get way sicker on antibiotics. Um, I see more reaction with the cancer patients. If they have micrometastasis in the bones, it seems like it creates a little inflammation there, and their bones hurt, especially if I give them IV vitamin C soon thereafter. But with this, I mean, like, yeah, it's super safe. And then so this is like some of the different sources on there, some my contact information. But one thing I want to mention this too is this is just super important. Um, patients that are coming to us are like trusting us, and so I think it is super important to be not withholding at all, but to be like judicious and to be like really responsible. And so like I always am very honest with patients. It's really important to me not to ever upsell anybody anything, even though like for a lot of people SOTs can be a big money maker and they make like $1,000 margin on each SOT. So it could be like a really good boom for their clinic. But for me, like I like to just lay it to people straight. Like this is what I've seen. This is where I've seen it be really effective. This is where I've seen it potentially not work. And make sure that it's in alignment with their goals, desires, and their financial resources. Because ultimately, it can save them money in the long run because they get better a lot faster. But it is a big investment, right? So I just like to give people all the information ahead of time. And then for the people in here that are treating cancer, this is super, super, super important. I have people come to me, which you might have come to you too, and they think that some of these adjunctive therapies or complementary therapies or even like alternative therapies are going to cure their cancer. And even though there's a really good study by the company that makes the SOTs on cancer showing I think it's like a 70 or 80% efficacy on cancer, and it's even higher if they don't have chemo or radiation. I have never seen an SOT treat anyone's tumor of any significant size. 2 centimeter, 3 centimeter, 4 centimeters, 5 centimeters above, it's contraindicated. Lungs and liver is contraindicated. That being said, though, I've had patients who forewent like conventional traditional therapies in lieu of IVs and SOTs, and I've never seen them get better. So don't let a cancer patient talk you into giving them an SOT for their cancer and not doing a traditional therapy that could save their life just because I haven't seen those go well. And I wish that I would have known this before, and been a little more just had the expertise and experience to tell people that. So you got to do all the other things too, right? You like I said, SOTs are an amazing, amazing tool in your toolkit. And if I could give them to all my patients, I would give them to all my patients, bar none. You flag high for this, I'm gonna give you an SOT. They're a big hitter, right? And they're a big investment too. So be really judicious with them. I would highly encourage you to incorporate it into your clinical practice. What I did, I got trained with Dr. Terry Bime, who's a naturopath who I had the pleasure of working with in our clinic for about 3 years. But the company RDCC will do a training for you and then teach your IV nurses how to give it. It's really easy. My IV nurses always told me it was one of their favorite IVs because they saw people get a lot better, and it was super simple, super fast, really easy. These can be extremely effective. Just know that they're not a panacea, and give people the information, like give them the patient handouts on the SOT and all that, because there's so much information and misinformation on the internet too, right? But I think knowing all the things that you're already doing, like you're supporting methylation, you're supporting detoxification, all that, that's the difference between an SOT being super effective and SOT being a dud. And I think that's why our patients have had a really good success with SOTs, because we address all those things as well. So I hope that's helpful for everybody here, and thank you very much for your time and attention. Appreciate it.